Good evening, everyone.
Good evening, Dr. Jiro.
Please, let's just give a few minutes. Let's wait till quarter past 9, so that we'll have more people present before we start.
Okay.
Good evening, everyone. It's a pleasure to have us present for our clinical meeting for tonight. Sorry, we are starting behind schedule. At 9 o'clock, we were very few online. Hence, we had to give 15 minutes for us to start at 9:15. It's my pleasure to welcome every one of us to our clinical meeting for tonight. We're starting about now. Sorry, my video is off for now because I'm not home yet. I'm on my way back home. So I'll be anchoring without my video until I get to the house. So once again, I want to welcome National Chairman, our fellows of the society, fellows of the college, our professors, our directors, distinguished senior colleagues, and everyone present. Welcome to our clinical meeting for tonight. Before we start, we want to spend the next 30 seconds to say our individual prayers, at the end of which we'll kick off the meeting. So please, let's use the next 30 minutes to say our individual prayers. 30 seconds, sorry. So it's a pleasure to be gathered here to be enlightened this evening on the topic attention deficit hyperactivity disorder in children. And this topic will be extracted for us by no other than a distinguished presenter, Dr. Danladi Momodu, who was a volunteer NYC staff / core member COVID-19 testing team. And he has undergone several trainings, including project management, organization management with the Daystar Leadership Academy Lagos, project management with Foundation LinkedIn Learning in Lagos, marketing and communication strategy in Lagos, Design Thinking for Business Strategy and Entrepreneurship, University of Sydney. Brand and Product Management, IE Business School. No doubt, our resource person is truly endowed with a wealth of knowledge. So without much time wasting, I want to call on Dr. Danladi as he gives us his presentation. Dr. Danladi, please.
Thank you very much, Dr. Eju. The National Chairman, sir, distinguished fellows of the association, professors here present, and all other protocol duly observed. I want to thank you very much for this opportunity to present on this really important topic to my fellow colleagues. I don't take it for granted at all. I understand that today is fast spent and the time is already past 9. So a lot of us might be going to go and sleep. So I would just dive in very quickly. My presentation is quite long, but I'll do my best to keep it short. So if you permit me, I'll just quickly share my slides so that we can dive straight into the topic. Once again, it's really great to be here. Thank you for having me. So please kindly confirm if you can see my screen.
Yes, you can see it.
All right, thank you very much. So the topic is attention deficit hyperactivity disorder in children. And we're going to be looking at this topic within these blocks. I'll be giving a basic introduction. We'll go through the pathophysiology, signs and symptoms, the risk factors, management, prognosis, and very importantly, I made sure to include a case study to practicalize what this condition really looks like in an individual, in a patient. Then I'll go over to the pharmacist's role in management of ADHD, and thereafter we'll conclude the session. So to start off, I'd love to ask, I have a question before me, which basically is, what is ADHD? I know that a lot of us, in fact, basically everybody here on this call, we are all clinically oriented. But I just want us to imagine for a second that you go to the mall and you want to probably pick up some groceries, and you see a mother walking with a child, 2 children, let's say, and one of them particularly is just jumping around, despite the effort of the mother to make that child maybe sit down in the lobby and wait for her, she picks up some stuff. The child can't stay in one place, just fidgeting, moving around, making sounds. The average person who is not clinically oriented might make assumptions like maybe that child is not well trained, or the parents probably did a bad job in developing the character and the behavior of that child. Some people might even go as far as assuming that child probably has some, evil spirits. We could go the angle of spiritual sometimes in these issues in Africa. But thank God we are clinically oriented, and we can draw inferences that such issues might be related to some behavioral tendencies. Now, according to the Diagnostic and Statistical Manual of Mental Disorders, DSM-5, attention deficit hyperactivity disorder, ADHD, is a neurodevelopmental disorder which is characterized by impairing levels of inattention, disorganization, and hyperactivity or impulsivity. Now, these symptoms, they affect children across different blocks. They affect them academically, they affect them behaviorally, emotionally, and even socially. They're not able to function effectively in a social setting. And the symptoms usually appear as early as between the ages of 3 to 6, and it continues into adulthood most times. And so it's really a critical issue that needs to be given utmost consideration. Now, ADHD can occur, has different presentations, basically. The first is the inattentive type, and this is characterized by impairing levels of inattention in the child. So you see the child is unable to pay attention to details. They're unable to focus on single tasks. The second one is the hyperactivity impulsive type, which the children display behaviors like jumping up and down. They don't sit down in one place. Basically, it's characterized by maladaptive levels of hyperactivity and impulsivity. Then the combined type is one where a child exhibits a combination of both the hyperactive and the inattentive symptoms. So that's it about the presentations. These are the presentations of ADHD. Now, for the prevalence rates, ADHD occurs at the rate of 7.1% worldwide, 7.7%, 7.47% in Africa, and 7.6% in Nigeria. What this tells us basically is that the global prevalence of ADHD is it's similar to the local prevalence we have around here in Africa and Nigeria. So ADHD is not something that probably affects one race more than the other. At the global level, the prevalence is very much correlates to the local level. And it's been studies have found that the ADHD is more prevalent among males compared to females, with a ratio of 2.01 to 1. And so boys are more likely to be diagnosed with these conditions. And the reason for this is because boys tend to display the more hyperactive, impulsive type, where they are always everywhere, disrupting, while ladies tend to display the inattentive type, which is quite subtle and more difficult to diagnose. Now, moving over to the pathophysiology, we cannot talk about ADHD without referencing a very important part of the brain, which is the prefrontal cortex. As you can see from my slides here, I've underlined the prefrontal cortex and highlighted three major functions of the prefrontal cortex, which is impaired when ADHD is present. So you have attention regulation, you have planning, you have impulse control. I just highlighted all of those to emphasize some of the functions that are impaired when a person has ADHD. But zoning in particularly on the prefrontal cortex, the right hemisphere is primarily responsible for the regulation of attention, behavior, and emotion, which are affected by ADHD. Now, two hypotheses so far have been postulated to. These are the explanations of ADHD. These are the hypotheses that have been postulated to explain the pathophysiology of ADHD, because research is still currently ongoing to understand the factors or the causes of this condition. There's no single issue that has been implicated in the development of ADHD. So the first one is the catecholamine hypothesis, which basically refers to the fact that individuals that have ADHD suffer from weakened catecholamine signaling in critical regions of the brain, like the prefrontal cortex. So this basically tells you that the prefrontal cortex has an issue with communication, neurotransmission and communication in these patients. The second one refers to the fact that critical areas of the brain, like the prefrontal cortex, is impaired in structure and functions. And so the connection between the prefrontal cortex and the subcortical structures is what is responsible for the development of ADHD. Now, combining those two hypotheses together, we can arrive at a chart like this, which explains that the prefrontal cortex, which is part of the brain, requires a proper level of catecholamine stimulation for optimal function. Now, let's look at this chart very well. You will see that at the first, on your left, coming from the left to the right, you have that too little stimulation of the prefrontal cortex is indicative of untreated ADHD. And so such a child would develop unguided attention, and they have poor control of their impulse. And it's understandable. The prefrontal cortex, which is responsible for all those functions, planning, attention regulation, does not receive adequate stimulation. and so the child would be unable to control their impulses and they will always be distracted. But when you have an adequate level of stimulation of the prefrontal cortex, you have the individual develops guided attention, they're more organized, and they're very, very flexible. This is indicative of an optimally treated ADHD. But when there is excess stimulation of this part of the brain, which is characteristics of probably an overdose or abuse of some stimulant medications, you have mental inflexibility, and they tend to become worse, misguided attention and responses. So this chart basically shows, it brings those two theories together in explaining the pathophysiology. Now, this slide basically zones in on the particular aspects of the right prefrontal cortex that regulates attention, behavior, and emotion. So the dorsal portion is connected to the sensory cortices, the lateral portion connected to the cerebellum and regulates behavior, then the ventromedial portion of the right prefrontal cortex regulates emotion through connections to the amygdala, hippocampus, and brainstem. These are subcortical structures. And I just included this slide here to show you some of the connections between the prefrontal cortex and the subcortical structures like the thalamus, the striatum, the cerebellum, and also to the cortical structure like the parietal cortex. Now, what are some of the risk factors in the development of attention deficit hyperactivity disorder? The first on my list here is family history. And this basically tells us that once a parent has people who develop, if you look at the people who come down with ADHD and you go trace their family history, you're likely to find a trace of this condition. So if a parent, for example, has an attention or behavioral disorder, children are likely to come down with this condition. Cigarette smoking and alcohol use during pregnancy. This is very understandable because when the fetus is developing in the womb, toxins and chemicals like cigarettes can affect the development of the child and particular aspects of the brain. So they can come down with ADHD. Exposure to environmental toxins also. Then low birth weight and preterm babies. So when a baby is not fully formed before coming out of the womb, you also have that their brains and possibly the prefrontal cortex is also not fully formed. And that can lead to the development of ADHD. Then brain injuries and CNS infections. For example, if a child probably suffers a major fall or a major injury to their forehead, that could cause injury to the prefrontal cortex and lead to ADHD. The signs and symptoms of these conditions are basically classified into two, like I mentioned earlier. The inattentive type, you have these symptoms here. Inattentive, they tend to be inattentive to details and they make careless mistakes. And you also find them maintaining, it's really difficult for them to maintain attention. They have trouble listening and they fail to follow through tasks. They lose things easily, they are easily distracted and they forget things easily. And for the hyperactivity symptoms, like I mentioned earlier, you have them fidget excessively, they can't stay seated in one place, they are always restless. They find it difficult playing quietly. So when you see their mates playing with a toy, maybe somewhere, they would be, you look at them this moment they are here, the next moment they are at the other end. They talk too much. They have difficulty waiting for their turns. They are very impatient. And they tend to interrupt or intrude others while they are talking. And so as you can see, the inattentive symptoms are 9, and the hyperactivity and impulsivity symptoms are 9. These symptoms are characterized according to the DSM-5, the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition. So how do you diagnose ADHD? For children less than 17 years, a proper diagnosis of ADHD requires that they have at least 6 symptoms of either hyperactivity, impulsivity, or at least 6 symptoms of inattention. So to diagnose the inattentive type of ADHD, the patient has to display at least 6 symptoms of 6 inattentive symptoms. And to diagnose the hyperactive type, you need to display at least 6 symptoms of hyperactivity. Now, these symptoms to meet the criteria for diagnosis, these symptoms must occur often, and they must be present in more than one setting, particularly at school and at home for these children. The symptoms must also persist for at least 6 months and must be present before the age of 12. Also, and very importantly, the symptoms must impair the function of these children academically, socially, and in the case of an adult, it tends to impair the occupational activities. The symptoms must also be excessive for the developmental level of the child. Now, what this point basically is this last point is trying to explain is we know that children can be quite disruptive when they are very young, they are growing, and so they still have issues managing their impulses. But as children grow older, they tend to put their impulses under control. So at a particular age, if a child is not able to, if maybe they're not able to outgrow some of those impulsive behaviors and they are displaying some disruptive behaviors, then that's the definition of being excessive for the developmental level of the child. So this is the criteria for diagnosing ADHD. Also, in doing your diagnosis, you have to rule out different conditions. And most times, these conditions tend to coexist in children with ADHD. So you have developmental variations, neurobiological or developmental disorders like language and learning disability, autism. You also have emotional and behavioral disorders, OCD, PTSD, psychosocial or environmental problems, and other selected medical conditions. These are the differential diagnoses, and these are the conditions you need to rule out if you need to make an accurate diagnosis of attention deficit hyperactivity disorder. Now we'll move over to the management, which is the bane of our practice at pharmacists. The first management strategy here is the non-pharmacological aspect. And this non-pharmacological aspect is usually recommended as the first line in the management of ADHD. The first one here is psychotherapeutics, and this basically speaks to behavioral therapy and family therapy. Behavioral therapy is about helping the children and adolescents who have ADHD develop appropriate social behaviors, because the ADHD patients tend to function poorly in social settings. So the goal of behavioral modification is to help them cultivate appropriate behavioral skills that will help them function effectively in society. Family therapy talks about helping parents understand the condition first and help their children to live effectively and successfully with this condition. So a lot of parents who have children with this condition, it can be quite a lot on them, So that's the goal of family therapy: help parents to understand this condition and manage it very well. School or educational intervention basically involves working with the teachers and educational institutions to ensure that children with ADHD have tailored training. You cannot place a child that has ADHD in the same class with every other normal functioning child. Obviously, they are learning verticals, they are learning goals, the learning curve is going to be different. So you basically have to tailor their educational plan and ensure they are able to learn properly and cultivate educational skills. That's why educational interventions are important. And for the pharmacological management, this involves medications like stimulants and cognition-enhancing medicines. The first-line medications used in the treatment of ADHD, which is approved by the Food and Drugs Agency, includes amphetamine derivatives, particularly methylphenidates. This is the bane of pharmacotherapy in the management of ADHD. We also have other medicines that can be used, like amphetamine, amoxicillin, and guanfacine and clonidine, which belongs to other classes. So methylphenidates is the first line pharmacotherapy used in the management of ADHD. There are also adjunct therapies which are useful in some cases. You have risperidone, cognium, and mentat. Now let's go and let's see how some of all these medications act in the management. Methylphenidate is a stimulant medication, and it is thought to inhibit dopamine transporters in the cortex and the stratum of the brain. About the cortex, that would particularly be in the prefrontal cortex, because that is the part of the brain that is implicated in the manifestation of ADHD. So methylphenidates basically blocks the uptake of dopamine and norepinephrine into the presynaptic neurons. The neurotransmission, I'm sure we understand that neurons are, neurotransmitters are released from the presynaptic neuron to the postsynaptic neuron for effective neurotransmission to occur. So in an ADHD patient, the neurotransmitters are not adequately and are not optimally available to act on the postsynaptic neurons. So the goal of methylphenidate, what methylphenidate does is to block the reuptake of those neurotransmitters back into the postsynaptic neuron so that it's available to work on the postsynaptic neurons. And the dosage for methylphenidate is given 5 milligrams once or twice daily, and it's increased by doses of 5 to 10 milligrams if necessary, titrated to a maximum daily dose of 60 milligrams, which can be given in divided doses. So that's how methylphenidate basically works in the management of ADHD. Very common side effects you have with methylphenidate, because it's a stimulant, it causes headache. You could also have abdominal pain, decreased appetite, nervousness, and particularly important, changes in blood pressure and heart rate. What this means for the clinically oriented pharmacist is that you have to monitor a patient who is on methylphenidate to ensure the treatment is having the optimal outcomes. Also, when initiating therapy, you also have to take notes, to take into consideration the cardiovascular status of that patient before initiating therapy. Moving over to risperidone. Like I said, risperidone is an adjunct medication. It is primarily an antipsychotic, which works by blocking dopamine and serotonin receptors in the mesolimbic pathways of the brain. And the mechanism of action of risperidone is not totally clear, it's unclear, but it starts to work by blocking these receptors, particularly in the mesolimbic pathway of the brain. And in psychiatric pharmacy, we know risperidone is an atypical antipsychotic, basically works for positive symptoms of psychosis. Some of those symptoms like aggression, when patients are becoming very disruptive. And in ADHD, some of these children tend to display that behavior, agitation, wandering, impulsivity, and aggression. So risperidone is indicated for this conduct and disruptive behavior, and so it's usually effective for this particular issue in children with ADHD. It's given at a starting dose of 0.01 milligram per kg once daily and adjusted by increments. So risperidone is administered on a weight basis based on the weight of the child for children between 5 to 12 years. Some of the side effects associated with risperidone include extrapyramidal syndrome. And this is basically a situation, is basically a syndrome associated with most antipsychotics, where the action of the medications in the brain, in pathways of the brain, like the nigrostriatal pathway, causes the patient to develop movement disorders like Parkinsonism. They also have tardive dyskinesia and a lot of other symptoms. You see them excessive salivation, also acute dystonic reaction. So these are some of the primary side effects that can be observed with risperidone. And to curb some of this extrapyramidal syndrome when observed in patients, you usually administer an anticholinergic agent like benzhexol, and also there's a particular piperidine injection. It's given to curb some of this extrapyramidal syndrome observed in patients taking risperidone. Cognium is a herbal tablet, and the purpose, it's basically given to manage the forgetfulness and difficulty with attention symptoms associated with ADHD. If you go back to the slide where I listed the symptoms, you would see that a primary symptom of patients with ADHD is that they tend to forget things easily and they don't pay attention. They have difficulty paying attention. So as a cognition-enhancing medication, Cognium helps is administered primarily for this function, and it's given at a dosage of 1 tablet daily. Mentat is also a herbal tablet which enhances memory and learning capacity. So to help these patients improve their memory quotient, their memory span, and their concentration ability, Mentat is a herbal tablet which is given at a dosage of 1 to 2 tablets every day. It has some side effects like diarrhea and stomach upset, which usually resolve as the body adjusts to the medications. Now, speaking about the prognosis, what's the possibility for effective or excellent management for patients with ADHD? And it basically boils down to 4 points that the prognosis for ADHD is really, really excellent when some conditions are met. The first one is that the patient has no major comorbidity. The appropriate patient education about this condition, ADHD, and its management is given to the family and the patient if it's an adolescent and an adult. Then also, they have to always adhere to their drug therapy. The fourth point here is that appropriate diagnosis and treatment of all coexisting disabilities. Like I mentioned earlier, ADHD occurs most times with other disabilities like learning disorders, you have autism, you have speech disorders. So to really get an excellent prognosis, you have to rule out other conditions and ensure that you are able to arrive at an accurate diagnosis of any other coexisting, any other coexisting morbidity so that you can treat ADHD effectively. And as you can see here, 70% of those who use methylphenidates see improvements in their ADHD symptoms. So really, ADHD is not a death sentence. Moving over to the case study now, this is a particular case I saw during my time at the Federal Neuropsychiatric Hospital in Benin City. So the patient is a 10-year-old male, kindergarten, weighing 38 kilograms, is the 5th child in a monogamous family of 5 children. He was observed very well until he was 4 years old, and his parents observed that he was not exhibiting age-appropriate behaviors, like we mentioned earlier. So he presented initially at UBTH, where he was treated until he was referred to the psychiatric hospital for additional interventions. One was clinical presentations. He came with poor speech, very restless, inability to stay still, jumps around, and the behavior was always at home and in school. Classical of what we talked about earlier, those symptoms. He doesn't wait for his turn, cannot tie his shoelace, very poor academic performance. So ADHD really affects the performances of sufferers, of children who have this condition. The family history shows that the father is 77-year-old, the mother is 52-year-old school teacher, and there's no known history of mental illness in the family. Medical history and developmental history information was insufficient. On physical examination, the child was observed to be not pale, and mental states, he appeared absent, activity level, very impulsive, and speech was absent for this child. What was the diagnosis? The diagnosis was mild to moderate learning disability and hyperkinetic disorder. Now, hyperkinetic disorder is also another term for attention deficit hyperactivity disorder. There are two classification standards, the DSM-5 and the ICD-10, that classify mental disorder. So the ICD-10 criteria defines ADHD as hyperkinetic disorder. So it's basically the same thing we're talking about here. The management plan for this particular child was placed on methylphenidate tablets, 18 milligrams daily for 2 weeks. And the particular brand here is Concerta, which is a sustained or extended release preparation of methylphenidates. It was also placed on Respiratory, 1 milligrams synoptic for 2 weeks, and sodium valproate, 200 milligrams for BD for 2 weeks. And it was also recommended for speech therapy. Now, what was the outcome of this treatment plan, basically? they saw an improvement in his symptoms, less hyperactivity, improved attentiveness. So we can see that the plan and the medication really improved OA's symptoms. Now, some of the challenges with managing this condition, ADHD, which a lot of parents and even care providers experience, is that the drug can be quite expensive and not very affordable for the patients. And so they have to sometimes resort to other alternatives, like probably Respiratory, which is easily accessible compared to Methylphenidates. A lot of persons may even have to go to the point of making orders from outside the country before they can treat their patients very well. And it's also not available in most retail pharmacies and some hospital pharmacies. And this is understandable. Methylphenidate is not exactly a fast-moving drug it's not a fast-moving drug like maybe amoxicillin, clavulanic acid, or anti-malaria tablet. So it's understandable that it's not readily available for most retail pharmacies because many of them don't want to run at a loss. But it's actually a challenge with managing this condition and should be given more attention. Now, what's our intervention as pharmacists in the management of ADHD? Basically, we have to work collaboratively with interprofessional teams, the doctors, the nurses, and other healthcare providers to optimize the patient therapy. So dose management and patient monitoring is really crucial in this aspect, because as we saw that some of the side effect profile of these medications can be really discomforting. Also, we can provide direct patient care, including treatment, assessment, and medication management. We also monitor for adverse drug reactions, like we said, and interactions. Patient education and counseling of the relatives about this condition is also very important. Parents need to know that if your child has ADHD, it's not a death sentence. You just need to know how to manage them effectively, adhere to their therapy, and help them to live more effectively with society and relate very well. Adherence is also key to ensure that the treatment of ADHD is optimal, optimal treatment. In conclusion, I would just say that ADHD is a serious public health problem in children and adolescents in Nigeria. It's not like most other mental and psychiatric conditions. It's not given enough attention. And so it's something that really needs to be looked into. The spotlight needs to be put on mental issues and ADHD in children so that you're able to raise adults that can function effectively in society. The pathophysiology of ADHD still remains poorly understood, despite the numerous research and literature on this disorder. So what this basically implies is that more research, greater resources has to go into research on this subject, studying the disorder and trying to understand newer frontiers in the management of this condition. Family support also is a crucial intervention. So besides the medications and the non-pharmacological approach to managing ADHD, the family aspects of managing this condition is very, very important. The first social system a child is introduced into is the family. And so if the child doesn't receive adequate support in this journey, because ADHD is a chronic condition. It's something a lot of them have it from childhood into adolescent and even into adulthood. If you do a YouTube search on ADHD, you will see different testimonials of people who navigated their life and their careers and even their marriages with this condition, some of the issues they went through, some of the failures they went through. And so the family is a very, very, very important system in supporting people with this condition. In closing, treatments can help to minimize ADHD symptoms. So like I said earlier, methylphenidate has an excellent profile in managing this condition. As a result, early diagnosis and treatment of ADHD can make a very, very big difference in outcome. So it's encouraged that people with these conditions should always should seek medical attention so that they can be effectively attended to. Thank you very much for having me on this call. These are some of the references preparing this presentation. And once again, I want to thank the chairman, the distinguished fellows, and everyone here present for this opportunity to give this presentation. Thank you very much. I would take any questions you have now.
I want to say a big thank you to you for this wonderful presentation. It's been truly informative and educative. Once again, thank you, Dr. Danladi Momodu, for the presentation. I want to use this opportunity to acknowledge the presence of our national chairman, Dr. Joseph Madu. And I see we have a group of professors present. I want to welcome all. The floor is now open for contributions, questions, and comments. Okay, Dr. Faith Iriperi, your hand is up.
Okay, good evening, everyone. Thank you, Dr. Momo, for this wonderful presentation. I just wanted to ask, you said the prognosis for this condition is very good, and we actually saw it from your slide. But I wanted to know if there is hope for complete recovery in these patients. And for this particular case that you discussed, how did the patients and how well did the patients do? Did he completely recover? The speech therapy and all of that, was that followed through? So I just wanted to know how the patient did on the therapies that the patient was placed on, and if there's complete recovery for patients that have this kind of condition. Thank you.
Okay, thank you very much for that question. For this patient in particular, OA, I followed his medication, his file for, I think, about, I followed his medical plan over a period of time, and what I saw was that there were different points where the patient was not on his medications. Was not on his medications, that's methylphenidates, and the observations at that point, at those different points in time, were that his symptoms grew worse. The symptoms grew worse when he was not on the medications. So when he was eventually placed back on methylphenidates, he bounced back. He was able to manage all his inattention and hyperactivity, impulsivity. Now, for the speech therapy is a long-term plan. So there was no definitive statement on the outcome concerning the speech therapy intervention. Like I said, I followed his plan for about 2 weeks, and he's an outpatient who comes regularly for treatment. So his plan was like continuing care. Now, about the aspect of, is there hope for complete recovery for patients of ADHD, for ADHD patients? Like I mentioned, ADHD is a chronic condition, and so from my research, from my studies, and even in some of the cases I saw, these patients tend to manage this condition over a long period of time. It's something that is mostly associated with a structural and functional issue of the brain. So it's not a one-off issue. The patients have to be on their medications continually to be able to function properly. So it's not something it's not something that patients recover from completely, but it's a manageable condition. So I hope that answers your question.
Thank you.
You're welcome.
Also have another hand there. Patricia Kukiga.
Okay. Thank you so much for this opportunity to, put this question across, and especially your presentation. As we all know, or you have explained, mental illnesses are chronic and usually lifelong. So in your course or your studies on mental health, especially this particular condition, ADHD, is there any correlation between this particular condition and any other mental illness like depression, schizophrenia, psychosis, delusions for these particular patients who eventually, mature and get older in life? Is there any correlation between this particular one and any other type of mental illness later on in life? Thank you.
Okay, so based on my research on this particular topic, there's no direct correlation between ADHD and some of all these mental issues listed. I'm just going to the slide where, yes, the differential diagnosis. What I, however, observed was that ADHD usually most times is not, it doesn't occur as a standalone condition. So you have neurological disorders like language and learning disability, autism, intellectual disability. So children who present with ADHD usually have these conditions as a comorbid, as a coexisting disorder alongside ADHD. But in terms of a particular direct correlation with, we probably say the child has ADHD and usually psychosis alongside, there's no direct correlation from research and all the previous studies conducted. However, one thing that is important to mention is that the critical risk factor in the development of this condition is a family history. So if parents, if there's a psychiatric issue or a psychiatric condition existing in the lineage, particularly that borders on anxiety and attention issues, then there's a probability or a tendency for children to develop ADHD along the line. I hope that answers your question.
Yes, thank you. Thank you.
You're welcome.
Thank you very much. We have more hands. Okay, Dr. Fejiri, like your.
Okay. Yes, I just wanted to say this. I remember when I was also doing my internship at Psychiatric Hospital Suselu, where he also did his, we saw something like this. And there was this correlation that was actually put out. I think people who, or children who have ADHD have a higher degree of coming down with schizophrenia later in life, more than others who didn't have that condition. So the presenter can research that as well. I think there's a correlation. Others can also make contributions to this regard. Thank you.
Thank you.
Thank you very much, Dr. Faith. I would look that up.
Do we have more comments, questions, and contributions? I think I would like to ask a question at this point. Particularly pleased with the mention of the herbal medicine management. So I want to ask, are there any documented interactions between the herbal formula you mentioned and other medications patients also be on?
So the first line medications that a lot of these patients, ADHD patients, are usually placed on, like I mentioned, is methylphenidates and occasionally amphetamines. Now, they are given as single treatment options, not together. Then you also have in the adjuncts as you have risperidone. So far, so good. There has been no documented interactions between the herbal medications like cognium and menthyl, which I talked about earlier. There's no clear-cut drug-drug interaction between those herbal medications and the first-line agents used in the treatment of ADHD. In fact, as adjuncts, the supports and I don't want to use the word potentiate, but they are really effective as adjuncts in the management of these conditions, alongside methylphenidates and other stimulants medications like amphetamine.
Thank you very much for your response. At this point, I want to call on the national chairman for comment.
All right. Good evening, everyone. Please, can you hear me very well?
Loud and clear.
All right. The sound at my end here seems is low. The sound here, I can barely hear the moderator and the speaker at times, though it has been intermittent. But I want to appreciate everyone who has attended this meeting tonight. I want to most importantly thank the presenter and the presenting state, Edo State. Then the members, the people that have attended this meeting this night, because without members in this meeting, there will not be any, or without audience, there will not be any presentation. Please, I want to plead with every person here tonight. I can see different states. It appears almost every state has one person at this meeting tonight. Please, I want to plead with us that as you go back to your different state platforms or different states, you encourage your members. The attendance to our meetings is still very poor. In SIPAN, we have at least 700 registered members. But how many people are we seeing at meetings? This night is just about 50 or 51. This is very, very poor. Less than even 0.1% or so. So please, let us encourage our colleagues, because if you are only an isolated, well-developed pharmacist, it will not make much impact than when we are more. There is confidence in number. So that's all I would like to say this night. Let us encourage our colleagues to keep on sharpening their brains. It's not all about work. Once in a while, you relax and sharpen your skills. And that is what we continually do at these meetings. You will agree with me that some of us have always attended these meetings almost every week for the past getting to 3 years now. And that is enough to make one a professor. So I know most of us that have been attending these meetings, we are already professors in practice, even though we are not maybe professors on paper. But it's more important to be a professor as a human being than just as in ordinary paper. On that note, I want to once again appreciate the moderator for giving me the opportunity and to wish us, all of us, a lovely night. Thank you.
Thank you very much, Dr. Joseph Madu, our national chairman. In fact, it's nice that the national chairman brought this up. We're about 6 as at 9:03. So we had to wait till about 9:15 before we got to about 20 or there about 27. Need for a lot of encouragement and awareness at our state level so that we can increase the level of participation at our meeting. Thank you very much, National Chairman. Do we have any other comments, questions? Okay, in the absence of...
Hello, can I say something?
Please go ahead.
Good evening, everyone. Dr. Chido Okoye from Enugu. Well, I want to appreciate the presenter. He did a very good job. So I joined in the middle of the presentation. But the ones I listened to, quite good. And I'm particularly happy he mentioned integration of herbal medicine in the management of ADHD. That's commendable. Because the new movement now is called integrative medicine, a situation where you incorporate alternative medicine and in addition to orthodox medicines in the treatment of patients. So I think it's the right way to go because each of the different areas have their areas of comparative advantage, and but for a chronic case like ADHD, particularly concerned about side effects and adverse effects of some orthodox medicines, especially as they'll be taken for quite a long time, So I suggest that, well, going forward, practitioners, medical practitioners should accommodate other forms of medicine and incorporate them into their treatment plans. Integrative medicine is a new movement, and it will be better for the patient. Thank you very much.
Thank you very much for your contribution. Once again, we want to especially thank the presenter, Dr. Danladi, for a wonderful presentation. In the absence of any more contributions, we would like to bring the meeting to an end. However, before we do that, can we have someone say a volunteer to say a closing prayer? Okay. It looks like we want to say our individual closing prayers again. So in the next 30 seconds, can we quickly say our closing prayers individually, and then we'll wrap up. So once again, thank you one and all for making this clinical meeting for tonight a success. We look forward to our next meeting together. Good night. God bless.
Good night, everyone. Good night.
Good night. Good night.
Good night, everyone.
Good night,
Thank you.
everyone.